Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same.
Hello, everyone, and welcome. We are now deep into season 7 of the Sleep is My Waking Passion podcast. I have a really, really cool guest for you today. This is a board-certified OBGYN. It's Dr. Meryl Kahan. Is that the right way to say your last name?
Khan.
Just Khan. Just
Khan. One syllable, yeah.
Kahan. Khan.
Okay, that's right.
All right, so I have been sort of being the creepster internet stalker, and I have looked at her website and some of the work that she's done, and I just felt like she was available and actually wanted to give me her time. Thank you so much, Meryl. I really appreciate that. So just by way of training, Meryl was a resident at Thomas Jefferson. She went to med school at SUNY Upstate, and she is the founder of SheMD Integrative Gynecology and Wellness in New York City. She offers personalized care. Yeah, it's gynecology, but it's also menopause and hormone optimization, weight management, aesthetics. Like, she does a whole gamut. It's really very comprehensive sort of creation that you've developed. And she's basically helping women feel and perform their best at every stage in life, which I just love that comprehensiveness. She created a direct care practice by the kind of in-depth personalized care, you're speaking my language, to women in need who don't often receive what they need from traditional insurance-based models. She also does telehealth services in New York State. So she's creating a greater access to care, which is sorely, sorely needed. Meryl, I just was on Capitol Hill advocating for the importance of preserving telemedicine and reimbursement for telemedicine because it is so, so vital and necessary. And we take it for granted that since the pandemic, everybody's been doing it, but it was all being done under some like emergency kind of situation. So it can expire and it can go away, which is mind-boggling because it's a part of our institution now. It's how we deliver care to patients. So welcome. It is so wonderful to have you today.
Thank you so much for having me. I'm excited to be here.
Yes, I'm going to have all of her handles and her website and all that great stuff that are listed in our advert. But Meryl, I want to start off by saying we are speaking very much the same language. I started a sleep telemedicine practice specifically because, I didn't want to be in a situation where it's like a volume issue. The more volume I see is how I'm going to, quote, survive. That to me is insane when we spend as many years in training as we do. But I also wanted to be able to say, all right, I'm having patients who have real difficulty sleeping. And one of the challenges I always had was, that overbooking, maybe they only got 20 minutes with me. And some of my patients were waiting up to 6 months to see me because there was an access issue because of the high volume turnover kind of nature of things and just how medicine is so quickly evolving and changing in the context of having a lot of challenges. So what led you down this path toward creating this whole integrative wellness platform for women? How did that come about?
Well, I think you're touching on 2 points right now. So one would be, how did my practice and the idea of offering the services that I offer come about? And then also in more of a direct care model, which is not the traditional way right now. So I had been in practice for about 9 years prior to starting SheMD, and I'd worked in a couple different private practices as a regular OBGYN, delivering babies, seeing people in the office. And I also spent some time working in the hospital setting. And common theme was just, as you said, you have to see so many patients, 15-minute slots. And as a way to keep the volume up so that you can get reimbursed by insurance for seeing that many patients in order to cover costs. And when you're really limited on time like that, you simply cannot get into learning about the patient's individual needs, their lifestyle. It's really hard to get away from that one-size-fits-all approach. And so when we're talking about women's health and hormones, which plays a major factor, that means what we end up doing when patients would come in, whether they're having certain issues with their periods, whether they're having issues with sleep, mood, libido, whatever it is, we're giving them a Band-Aid, and that Band-Aid often just looks like birth control or sleeping pill, and there's not really time to get into anything else. And sure, maybe that helps some of their symptoms, but it's really not getting to the root cause of what was going on. So it's kind of a temporary fix. And birth control also is not without its own issues and side effects for a lot of women. So that is how I used to practice, and that's how all of my colleagues practiced. And we really didn't get much training in residency, and most OBGYN residencies really do not give any menopause training. And so I opened SheMD, but prior to that, I became a Menopause Society certified practitioner because I knew that I wanted to focus more on that and be able to actually offer help to these patients who clearly were in desperate need of it and just not getting it from any doctor. And who else were they supposed to turn to? I stopped doing obstetrics to really be able to give that time to them. That means operating outside of that traditional insurance model. And that can be a tough thing for a lot of patients to really understand. You know, I'm paying for insurance. I'm paying a lot for insurance. Why would I see a doctor that is outside of insurance? But then once they experience the longer visits, you know, an hour-long visit, sometimes longer, when they experience not having to wait months to get an appointment, when they experience getting certain specialty testing done and plans that work specifically for them, when they experience being able to literally text with me in between visits if they have any questions, as opposed to having to call the typical doctor's office, maybe not even getting through, leaving a message. Maybe they'll hear back, maybe from the doctor, maybe from a nurse, you know. So this really makes it a much closer relationship between myself and the patient. And I've been able to see the results that they're getting because of this. And then on top of that, you know, I really wanted to be a place like a one-stop shop for women. That's why I brought in aesthetics, because it's not just about, you know, how you look on the outside, but that really can impact a lot in terms of confidence and how you feel about yourself. And so I wanted to be this place where women can come, form a good relationship, a trusting relationship with me as their women's health doctor, and I can help them achieve their goals in their health, wellness, and beauty.
I think this is, you really, really chose to get extra training so that you would be able to truly understand and manage your patient population. And there's such an unmet need. I think it's so great to see in Hollywood women in our generation who are now aging and going through menopause and actually being willing to talk about that experience and the weird stuff that happens. And I've seen so many times, and I almost feel like if I had to go back in time, I would have handled that case differently, because so many times women will come to me specifically to see me for a sleep complaint, but a lot of their other symptoms are things where I almost feel like I'm that person who's like, oh, maybe we should send you to ortho because your shoulder's bothering you, and some of these weird little symptoms. So can you go into a little bit for women who are just trying to figure out what's going on and what's changed in their body? What are some of the weird symptoms to be on the lookout for? How do we put all this together? How do you sort of counsel women that are coming to you? And maybe what are some of the key complaints that they're coming to you with that lead you down this perimenopause, menopause path?
So menopause is actually oftentimes more straightforward to figure out than perimenopause, because menopause by definition is you have gone a full 12 months without a period. And then there's the accompanying symptoms. Not everyone will get them. Not everyone will get all of them, but what we've all heard of, the night sweats, hot flashes, maybe libido changes, that kind of thing, along with not getting their period. But when it comes to perimenopause, that is oftentimes a bit trickier. And because of that, so many women are really brushed off with their regular doctor or their regular gynecologist because they're told, well, you're still getting your period, you're too young, this is not menopause or anything related to that. But that's not true, and we know that now. And so a lot of the symptoms that are not those typical ones that we think of can include things like brain fog. It can include joint aches, like frozen shoulder, heart palpitations, sleep issues, fatigue, hair changes, and a big one is also weight gain, or they're noticing a redistribution of weight where now they're carrying more in the belly area, where maybe before, they were able to change their diet for a bit, work out a little bit more, and it would go back to their baseline. And now they're finding that whatever they do, it doesn't seem to make a difference. That weight is just not budging.
Do you find that sometimes because women are on birth control pills, does that impact their ability to detect what the heck's going on? Because I've just heard of people being like, well, I'm in birth control for like ever. I never get my period. I don't know what the heck's going on. And how does that work?
Absolutely. Birth control completely makes the picture even more confusing. As I mentioned earlier, that is something that typically what I used to do and what a lot of doctors still do is give women birth control if they're not already on it to help regulate these symptoms like irregular periods. So if someone is on it, honestly, whether they're getting their periods on it or not, if they're on it and not getting their periods, it's not indicative of menopause. It's just the way the pill works. Some pills, you just stop getting your period on it. And so we're not then able to look at the menstrual cycle as an indicator of our hormonal status. And so then the next thing that we would consider doing because of that is looking at the actual hormone levels, typically through blood tests, but there are some other ways as well. Now, the problem is that when you are on the pill, your hormone levels are just not accurate. They're just low, not accurate. You can't base any sort of clinical decision on that whatsoever. And even for women not on birth control, but in perimenopause, the hormone levels, again, aren't terribly accurate because they fluctuate with the cycle. In menopause, your hormone levels go down, your FSH, which comes from the brain and stimulates the ovaries to produce more follicles, estrogen goes up. That's typical for menopause. And so we can rely on hormone testing in that population. But in perimenopause, your ovaries are still functioning, sometimes better than others. And so it totally depends where you are in the cycle, what your hormone levels will look like. So that's why it's very important during perimenopause that you really look out more for the symptoms. And that requires actually talking to the patient and hearing from her.
Oh my goodness.
Yeah.
What a fun.
Yeah, I know. It's a novel idea. But it does make it more difficult. And hey, some women are on birth control and it can mask the symptoms, as I mentioned. And so, they're happy to stay on it for the time being. And for some women, that might work for them. And you still can get pregnant until you're fully in menopause. And so a lot of women don't want to have to take that risk. And so if they're feeling, pretty okay on the pill or whatever form of birth control they're on, it's not unreasonable to keep them on it until the early 50s, when we typically think they might hit menopause and then go off and see what happens. But if they're on the pill and still kind of getting some of these symptoms I mentioned, it's worth considering maybe switching them from the pill to hormone replacement therapy. And I'm talking about bioidentical hormone replacement therapy, which is typically actually lower dose than birth control pills are anyway. But it's just a different type of hormone, and it matches what our body makes naturally. And so you're not likely to see the type of side effects that you may see in the more synthetic forms, like with the pill or with certain types of non-bioidentical hormone replacement therapy.
Are there any times when you use non-hormonal? What I mean is non-HRT. So somebody's not getting hormone replacement therapy. Are there options for patients that you'd like to mention, and how effective are they?
So that's a great question. And as more and more women are hearing about the safety of hormone replacement therapy, I think, that's a good thing, but it's important to remember it is not for everyone. And there still is a lot of fear surrounding any kind of hormone replacement therapy. So even though we now know that it is safe for most women, nonetheless, some providers are not comfortable and the patients are not comfortable. And this all stems from a study in 2002. Many of us have heard about this by now, but the Women's Health Initiative basically showed that there's increased risk of breast cancer, stroke, health issues with hormone replacement. But we now know that was using, number one, not bioidentical forms of hormone. And it was also primarily in women in their 60s. So that's about 10 years out from menopause. So those two factors are, potentially more, riskier. But when we're talking bioidentical, we're again talking about the natural type, and also typically you're starting in younger women, so it's more protective. So to answer your question, there are women who don't want it, and most are candidates, but for bioidentical, it's still a bit iffy. The big one would be for a history, personal history, not family so much, but personal history of breast cancer, especially if it was a hormone receptor positive breast cancer, meaning it responds to hormones. And so that one is still a bit confusing. Actually, I was just at a menopause conference last weekend, and this was a big topic as well. In those patients, you want to look at what are their major symptoms that they're struggling with. How is that affecting their quality of life? Are there non-hormonal options, which I will get into, that can help them? Of course, I would recommend starting with those, though you don't get other protections necessarily that hormones provide, but they may be enough to help those specific symptoms. And if nothing is helping, it's really worth the conversation with the oncologist, the patient. What is more important, your quality of life, or potentially knowing there may be a slightly increased risk of a cancer recurrence? That being said, recently an article came out that vaginal estrogen, which is not the same as hormone replacement therapy because it works only in the vagina and it's affecting only those tissues. So it helps with dryness, incontinence, recurrent urinary tract infections. That actually is safe to use in breast cancer patients, regardless of their hormone receptor status, because it acts locally and it's not getting absorbed in the body, which is great. I mean, I've felt comfortable using it for a long time, but I know patients hadn't, and oncologists could kind of go either way. So this is great that at least now we have more data to show its safety. For certain things like hot flashes, which is the major symptom we all hear about, there are hormonal options. There's the newest one called Veoza. This one actually works in the brain, really in the thermoregulatory center to help decrease the incidence of hot flashes. It is helpful, it's a pill that you take, but they've compared it to hormone replacement, and you're not going to get quite the same results, but it's certainly a very, very viable option for hot flashes. There are other medications. There's one called Bristol. It's actually Paxil, very low dose Paxil, which is an antidepressant. They have found that works for hot flashes as well. Gabapentin can be helpful for hot flashes and sleep. Yeah. So that's something. Yeah. So I've used that, especially, night sweats. So I've used that either nighttime and daytime, depending how it's working for them with their wakefulness. But that can help. Clonidine, it's a blood pressure medication. I'm not sure how much it's in use for that anymore, but that is another option. So there are these non-hormonal options for that specifically in terms of the hot flashes and the night sweats. For sleep, I'm sure you know all about all the options that are non-hormonal for sleep.
I would love to know in your perspective, because I don't recall seeing any, effusive data on this basically, but my experience has been that the biggest bang for your buck in terms of women that are struggling with sleep disruption, but it's specifically really kind of tethered to the vasomotor symptoms, the hot flashes that we talk about, feeling hot, palpitations, sweating at night, all those things that tends to wake them up and disrupt their sleep. If we can calm that mechanism down, what I have seen in clinical practice is the people who are on hormone replacement tend to feel the best. I've had a lot, even though these other options exist, I haven't had patients be like, whoa, I'm now on a low-dose antidepressant. My sleep has become magical, but I'm not going to say it's going to be perfect, and that's the nature of the beast as we get older. Regardless of whether you're male or female, our sleep architecture changes. We have less of that deep restorative sleep, more lighter sleep, and more sleep disruption. We tend to be sleeping a little bit shorter, just kind of by virtue of aging. But that hasn't been my experience. I was curious if that's been the same for you, or if you found that certain non-hormonals are working pretty well to improve sleep complaints, particularly insomnia or difficulty either falling asleep, maintaining a sleep, or that early morning awakening that we refer to.
Yeah, so before I really got into the whole hormone replacement and menopause practice, if women had sleep complaints, a lot of it would be talking about sleep hygiene, not something I liked to do, but on very rare occasion, give an Ambien or a refill if they had already been on it. I'm not a fan of that, but, or melatonin is a big one. And especially dealing with when I would see a lot of pregnant patients, that was a major complaint, was sleep issues. But you're right. No one really ever came back and said, wow, I feel so much better. I'm refreshed. I'm sleeping through the night. But now that I am practicing in the way that I am, the progesterone effect on sleep is like literally night and day. Forgive the pun there. But I mean, progesterone is the calming hormone. It's like the chill out hormone. And so it works. There are different formulations, but when you take the oral form of progesterone, it will cross the blood-brain barrier. And so it can act in the brain to help calm down everything. And the sleep that women are getting once they start progesterone, I mean, it works very quickly. They're not having to wait weeks to see this result. And they're sleeping through the night and they're waking up ready to get out of bed. Their first thought is no longer, oh my goodness, when am I going to get back into this bed tonight? You know, they're having energy and it's such an easy fix for them. And there are different schools of thought. I mean, the reason that women on hormone replacement therapy, we always think about the estrogen, right? And so that's really a mainstay for hormone replacement therapy. But the progesterone is important also to protect the lining of the uterus, to protect against uterine cancer, because when we give estrogen, it promotes the growth of the lining. So we need to balance that and keep that in check, because if the lining grows and grows and grows, it can cause down the road a uterine cancer. So progesterone is there as a safety mechanism. So then the question becomes, oh, what about women who've had hysterectomies? Do they still need progesterone? And a lot of people who are certified menopause providers, hormone replacement therapy providers, they will say, no, they don't need it. They don't have a uterus. I disagree. I really think progesterone is so important for the sleep. I mean, if you're not getting enough sleep, you're not able to function throughout the day. You're exhausted, you have no energy, your brain isn't working as well, you're more irritable. You know, it really is impactful. And progesterone also helps a lot for anxiety and irritability that a lot of women are finding, partially related to the sleep issue, but partially just on its own, right? That's happening during these hormonal changes. And so progesterone is so important for that. It helps with their personal relationships. I mean, they see improvements with their spouses and how they handle their kids, you know, who typically drive them crazy. They just see improvements in how they're responding to them. And so I find that progesterone is so helpful, regardless, like it goes beyond protecting the uterus. And so that's really, when it comes to sleep, that's what I have found to be the key player there.
I am so impressed and fascinated by what you're saying, because we as physicians can be guilty of looking very specifically at one typical parameter for how we're going to use, be it hormones or just a drug. And, you know, we define success a very specific way, typically by what a randomized control trial says. And we're like, okay, well, you don't have a uterus, you don't need blank, right? It seems very mechanical. I was initially going to ask you, what if you have just a tiny nubbin of a uterus, which is my case, just have a little tiny nubbin because I had to get essentially a hysterectomy immediately after my second baby. That was a wild ride. I, of course, was under so much anesthesia. I had no idea what the hell was going on, but my husband was, upset. And so you kind of answered my question for me, which is, probably yes, because there's at least some uterine tissue. But what's more fascinating to me is that you are actually saying, listen, I'm looking at the entire freaking patient. And if they're really struggling with their sleep, and I don't care if they have a uterus or not, the benefits may outweigh the risks, essentially. That's really, for anyone listening, as two physicians here, our ultimate goal, we took a Hippocratic oath, is to do no harm. We want to help people and do so in a way that really resonates with how we like to practice and how we feel patients should be cared for. Hence, we have very similar ideas about a direct specialty care model. But more importantly is the other aspects of it is that medicine is an art. And we often lose sight because we're focused on an algorithm, we're focused on certain parameters. And when you look at them, from the women's perspective, it's not just about the presence or absence of a uterus does not define our womanhood, right? And so I love what you're saying, and your observations are spot on. I say that. I have a friend of mine who is a sleep specialist, but she's very interested in menopause, and she had started on progesterone. she's a lot younger than me. So again, in my naivete, I'm thinking, what, but really she was having symptoms of perimenopause. And she's like, Alison, it is such engaging. Dry sleep so much better, so much better. So I know that's an anecdotal kind of thing, but what you're saying makes so much sense. And there is literature that actually supports that. We talk about progesterone being that calming hormone, and I love that you brought that up. So in your experience, in terms of the non-hormonal options, I would imagine you're probably having similar observations to me where maybe some things are a little bit better, maybe some of the vasomotor symptoms are better, so you have a little bit less sleep disruption. But I don't want to speak because you're seeing a lot more volume of those patients than I am. So I'm curious about if that's been the case, or if you mentioned gabapentin is sticking out as being pretty good for sleep. I was just curious about any of these other ones.
For sleep, magnesium is helpful. I don't know if that's something that you have used or recommended, but magnesium also can help calm down. And patients do fairly well on that one, as they can do it with the progesterone also. Sometimes melatonin can be helpful, but again, I haven't found that to be really sufficiently helpful. And some supplements, one thing that I look at is cortisol. That's our stress hormone. That's what makes me a little bit different than some other straight up hormone replacement therapy doctors who really only look at the sex hormones, estrogen, progesterone, testosterone. But cortisol is really important because all these hormones and cortisol have the same precursor hormone. And so when we're very stressed, which we all are at all times, your body needs the cortisol to survive. You can survive with low sex hormones. Women in menopause do it all the time, but you can't really survive for very long without cortisol. So that means everything's getting shifted towards that cortisol making pathway when you're very stressed, and that can impact your sex hormones too. So it's important to balance the cortisol, and there's no great way, there's not really like a hormone replacement specifically for cortisol, but there are what we call adaptogens that can help regulate it. And so something like ashwagandha, that's an example of an adaptogen that can be helpful for regulating that stress hormone. And so when your cortisol is very high, that can also lead to these awakenings. And so if we're looking at the cortisol too, with ashwagandha or phosphatidylserine, these can help lower that, stabilize it. I mean, we do want our cortisol up in the morning. That helps wake us up, but we don't want it up all the time. We want it to follow a specific cycle. And it's also not good when your cortisol is very low either. So that's why an adaptogen helps kind of keep it where we want it. And so those are another thing that can be added to the mix depending on someone's situation. What does their cortisol level look like to help keep them sleeping? So I think it's not just like try one thing and leave it at that, but you have to kind of look at the whole picture. And if one thing isn't working or it's working, but it can still improve, then you can try these other sort of more natural, non-prescription treatments as well.
I am fascinated by what you're saying, and I want to push the envelope a little and ask what your general approach is when women have difficulty sleeping. How many of them are interested, or do you discuss maybe even considering some form of sleep observation, be it formal sleep testing? They have home sleep testing options now. Multi-night tends to be better than single night. There's also home polysomnograms, but there's no official CPT code, so it's an out-of-pocket cost. It's certainly cheaper than going to a sleep lab for a polysomnogram, but I was curious as to when you pull that trigger, just because sometimes there can be a lot of overlap between a woman's symptoms in perimenopause, menopause, and obstructive sleep apnea, and then you can have both insomnia as well as sleep apnea happening together, something that we call COMISA. There's overlap with those symptoms. There's an uptick in insomnia. And then again, unfortunately, replacing hormones helps with certain aspects of the menopausal transition, but it doesn't necessarily fix obstructive sleep apnea. And we do see, I at least in my practice, definitely, women don't often complain of the same things dudes do. I cannot even tell you how many patients I don't really snore, or my husband. I mean, everybody probably snores a little bit at some point, but even if they have a bed partner, if that person's not really picking up on that, they're like, I can't possibly have sleep apnea. And then I've seen ladies who have incurred somewhat of a weight gain, but perhaps you and I would sort of chuckle a little bit about how mild that weight gain is because they're just very petite ladies with very thin airways. And it's almost like a phenotype that I see. I feel like they tend to be very kind of on the stressed side of things. They often will describe a lot of stress in their life, not a lot of sleep apnea symptoms. And I've had a couple instances now where I've tested them and picked up some sleep apnea. One was my very first experience was going, I'm not sure that you do. I didn't test her. And then she got tested by her dentist, which made me go, I'm never making that mistake again. I need to be the sleep doctor who can actually pick this up. And then another lady who we did pick up on testing. I mean, there's times when things appear to be pretty normal. And if I have a good waveform, I have very little data loss and I feel pretty comfortable. There's probably nothing major going on. It's not really that. But I was just curious if there's, if that's built into how you approach it, because I see that as being sort of something as an additional offering that could be really helpful. So I wanted to get your take on that.
Yeah, it's not something that I have routinely done, but it hasn't really been the forefront of what I'm thinking about when they're having sleep complaints. But I'm really glad that we're talking about this right now because, of course, I want to be able to offer any sort of diagnostic testing or solution to help my patients when it's needed. I've actually had that home sleep study myself after years of, waking up in the middle of the night. And now, yes, progesterone, thank you. Finally, I'm sleeping. So I think as far as how I would practice would be if I'm seeing them and they're having these hormonal-like, or I suspect them to be hormonal-like symptoms, and then I try all the things that we've talked about, and if they're doing better, no more sleep concerns, I feel pretty comfortable that we're good where we are, and there's no more underlying, there's no underlying other sleep issue that's not hormonal. Now, that being said, I think it's a great idea, of course, if they're still not feeling well, maybe they're sleeping more, but if they're still waking up completely exhausted, even if now they're getting their 8 hours, but they're still finding it hard to get out of bed, or they just want to crash in the afternoon or anything like that, I think it is important to not always just try to keep throwing things at it and manage it myself, but refer to others like you in the sleep space who have that capacity to think of other potential causes and also test for them and treat them if necessary. I mean, I'm not a sleep doctor, so there's definitely things that aren't on my radar that perhaps now, definitely now will be. But yeah, I can't do all of those things. So it's definitely important to have that sort of connection and escalate, I would say, as necessary.
Taught an expert something. That is amazing. If nothing happens with this episode, and hopefully everybody will be out there listening to this because it's really important. Meryl, thank you for allowing me to just have a platform to chat with you about that. It's one of my my latest obsessions because I think you're making really, really good points. There's such a component of hormone to it. Doesn't mean that everybody that you see is going to have some sleep disorder as being the answer, right? But conversely, kind of being able to do something that I think is so kind of simple and And I think a lot of women could be a little scared because maybe they have husbands that are wearing like a giant. They're like, oh, listen, I love my man. I want him to be alive, but I'm not strapping that, jock strap to my head to treat my sleep apnea. And for the listeners out there, I just wanted to add, and Meryl, you might find this interesting. There are so many cool therapies that are either in research or can be adjunctive. It doesn't have to be a mask and a machine. Yes, that is very effective. And people are often, they may have friends or relatives that have had a bad experience, and so they see it as being a negative. And if you're struggling with your sleep, you may also be like, I have to get used to this, and I've slept, 40, 50 years without anything, and now I've got to deal with this. But while it's very difficult, we are very adaptable, very resilient people just by the fact that we are women. I mean, I'm just going to state for the record, women are hardy, we're resilient, and we can get used to doing new things. So don't completely poo-poo CPAP, but I will say I've had a lot of success, especially with people with really good airways and who may be on the thinner side. They might do really well with an oral appliance therapy that's made by a dentist. For people with more significant sleep apnea but really don't want to wear a machine, there's an alternative, which is a surgical procedure called hypoglossal nerve stimulation. Inspire is sort of the main product out on the market, though there's several other products that are likely going to be in that space sooner rather than later. And then they're actually looking at medications that might help strengthen the tone of the airway. The progesterone's the calming hormone, but there's some stability in the airway that is thought to be hormonally mediated as well. And so if we can further stabilize the airway in your relatively mild sleep apnea, that might be the extra sort of edge that you need for management. So we'll see where that data goes. And then there's also new neat gadgets out there. I've been trying something called Modia Sleep. It does have an FDA CPT code, but they're not really using it because it's for a TENS unit. So reimbursement-wise, it's, a cost thing. But it looks like a headband that goes around. There's a couple of electrodes that go in the back of the neck that sort of stimulate the vestibular nervous system. And that sends signals to the hypothalamus, and it's almost like being in a car or being in a boat. So it kind of creates that sensation that kind of stimulates you to fall asleep. As a kid and even an adult on some days where I'm not a napper, but like if you put me in a car, I'm like, oh, I can relax and chill. Like there's something about that motion that's always been positive for me. If you're one of those people, that kind of type of apparatus may exist for you. And then I just wanted to throw in, Meryl, that one of the things that I do, and I actually got some certification for this, even though I trained with Jennifer Martin years ago, and I've been kind of doing this anyway in my clinical practice, is cognitive behavioral therapy for insomnia. There's all sorts of components to that. And you had mentioned something that's a real biggie, right? Regulating your cortisol. And you can have adaptogens and other sort of supplements that do that. But then you can also have just techniques like meditation, which some people get annoyed when you use that term. But really, there's something to be said about being able to sit quietly for just 5 minutes even. And it's really hard to do. And it's like a challenge. That's like your workout, your brain workout for that day. So I just wanted to make sure I threw that information out there with you because I think that you are doing some really wonderful work. And I'm hoping to round that out by nudging you to be like, get some sleep in there. Because SheMD sleep, beautiful idea. And I wish you the best. Take that idea and run with it, please.
Thank you.
Well, this has been such a fun conversation. Is there anything else you'd like to leave our listeners with? Because you're really doing a bang-up job at this great sort of very comprehensive center that you've created, and that's how I look at it. So,
yeah, I would say that if you find that you are having some of the symptoms we've talked about today and you're frustrated that you've spoken to your doctor and you're really not getting anywhere, please go find another doctor because there are plenty that are qualified and wanting to help you. And also, I will be starting telehealth in Florida soon too. So,
yeah. All right. Thank you.
Thank you so much.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.